mainly the lesions that should be covered are herpes, mainly the herpetic lesions, one second, just give me some, just few seconds. Once it becomes live streaming, I'll be able to, I'll start with the topic. Yeah, so we are going to start um, first with the viral infections, that too particularly the herpetic lesions. Herpetic lesions. So in the herpes, if we see here, there is a lesion here called as primary herpetic gingivostomatitis. Primary herpetic gingivostomatitis. So what is this primary herpetic gingivostomatitis? It's a due to HSV1. If you can see carefully here, the ulcers that can be seen here affect mainly the gingiva. That is why it is called as herpetic gingivostomatitis. You can see that in the image 1, there is a gingival inflammation, gingival involvement associated with stomatitis, that is inflammation of the mucosa. So this herpetic gingivostomatitis mainly affects the mucoperiosteal area. So if you see, concentrate on there, it affects mainly the mucoperiosteal area. What do you mean by mucoperiosteal area? The area which are the mucosa which is attached to the periosteum. That is gingiva. Gingiva has got an underlying periosteum, right? Bone. So mainly the herpetic ulcers mainly affect, primary herpetic ulcers mainly affect the mucoperiosteal areas. And these ulcers, they have got a erythematous halo. You can see carefully there. There is a red margin there. But remember, they will heal with no scar formation. And that too maximum within 1 or 2 weeks. Okay. Now, because of this, there is a term called as geometric herpetic stomatitis. That means the ulcers are located here and there in the oral cavity on the mucosa. The term that has been described as geometric herpetic stomatitis. Geometric herpetic stomatitis. Fine. So this image that we are discussing here is of the primary herpetic gingivostomatitis. Let us move to the next image here. The next image is of the secondary herpes simplex. Secondary herpes simplex. So what do you mean by secondary herpes simplex? Secondary here mean to say the reactivated infection. Reactivated infection. So secondary herpes simplex usually affects the lips, particularly the lips. And if you see the image 2 and image 3 carefully, secondary herpes simplex and secondary herpes simplex labialis, look at the speciality of the vesicles. Are they separate? No, they will be clustered. They will be clustered. So clustered vesicles is the key for identification of this lesion. So secondary herpes simplex is mainly the lesion with clustered vesicles. With the clustered vesicles. Okay, that's the second image about the herpes simplex. The same image you can see here carefully here. You look at the image, how it is. It is having a clustered vesicles. Having a clustered vesicles. Okay. Herpetic whitlow. What do you mean by herpetic whitlow? This image is showing about herpetic whitlow. What do you mean by herpetic whitlow? It is nothing but the herpes infection of the fingers. Okay, the dentist who is treating or the assistant who is treating the patient might contract the infection. That infection of the finger is called as herpetic whitlow. It is known as herpetic whitlow. Okay, next, herpes zoster. Herpes zoster is, this image is of herpes zoster. How to identify clearly? This herpes zoster mainly has got vesicles on one side of the palate. One side of the palate. Okay, typically you can see on this image the left side, both the diagram, both the images, you can see the left side only there are vesicles. So typically the vesicles will be there. Remember, these are very, very painful. Remember, herpes zoster vesicles will rupture and they will form ulcer, and these ulcers are very painful ulcers. They are very painful ulcers. And these ulcers or vesicles, they will follow a dermatome rule. Dermatome rule. What do you mean by dermatome rule? These vesicles will typically follow the path of one particular nerve. For example, in this image, it is involving the greater palatine nerve dermatome. So wherever the greater palatine nerve will supply, in that region you will see vesicles. In that region you will see vesicles. So dermatome rule is very simple. What it states is, it states that the vesicles will occur on the region, on the mucosa or in the region where the nerve will supply. Okay, that is the uniqueness of this herpes zoster. Remember, it is very, very strictly follows, it is unilateral, strictly follows the dermatome rule. Okay, this is an image of hand, foot and mouth disease. You can see carefully here, there is a vesicle on the hand, on the palm, on the foot, and there is an ulcer on the tongue. Remember, these ulcers never occur on gingiva and lips. This is a very unique point. Actually, this hand, foot and mouth disease is caused by a Coxsackie virus. Coxsackie A16. The virus is Coxsackie A16, and this Coxsackie virus, these ulcers or these lesions, they are never seen on gingiva and lips. Okay, they are typically seen on tongue. They are typically seen on tongue. So that's about the hand, foot and mouth disease. So how to identify this hand, foot and mouth disease? There will be lesion on hand, there will be lesion on foot, and then mouth. What about herpangina? Carefully look at the image. Herpangina. Again, it's a Coxsackie virus infection. Same like your hand, foot and mouth disease, that's also a Coxsackie virus infection. But note that on the palate, only the posterior palate is involved. Anterior palate is totally not affected only. You can see the redness area, the ulcers, all those are seen on posterior palate only, not affecting the anterior palate. So these vesicles which are seen on the posterior palate, they will rupture to form ulcers, and these ulcers, because of these ulcers, the patient complains of looks like it is a pharyngitis. Actually, it is not pharyngitis, it is a Coxsackie virus infection, but it looks as if it is a pharyngitis. Okay, that's a uniqueness of herpangina. So herpangina. So from this image, what we are supposed to learn is herpangina will have vesicles on posterior part of the oral cavity. Anterior part is normal. Infectious mononucleosis. Infectious mononucleosis is caused by mainly Epstein-Barr virus. Epstein-Barr virus. So this infectious mononucleosis will cause a petechiae on the palate. So this palatal petechiae image is very characteristic of infectious mononucleosis. Okay, this is a EBV induced viral infection. It's a EBV induced infection. So in these patients, typically this virus spreads through saliva. Okay, so virus spreads through saliva, and the typical oral manifestation in these patients is palatal petechiae. Petechiae, or which are nothing but the pinpoint hemorrhagic areas. They are called as petechiae. So these petechiae on the palate are considered to be the characteristic for these infectious mononucleosis. So these infectious mononucleosis. Okay, Koplik spots. Next, now what is Koplik spots? Koplik spots are typically seen in measles patients. measles infection, which is a paramyxovirus infection, measles. You can see carefully here on the buccal mucosa. You can see this, all those white, bluish white dots. All that is nothing but on the buccal mucosa is nothing but your Koplik spots. So uniqueness of this Koplik spots is they will appear almost 24 to 48 hours before the skin rash. So Koplik spots usually appear minimum of around 24 to 48 hours before the skin rash. That means if the patient consults a pediatrician or a dermatologist, before that a dentist can identify this Koplik spots. If you are able to identify, look at the buccal mucosa, bluish white granules like areas, granular areas, they are nothing but your Koplik spots. Okay, next, oral hairy leukoplakia. Oral hairy leukoplakia. What exactly is this oral hairy leukoplakia? You can see carefully this image. Again, it is of your tongue, lateral border of the tongue, and you can see carefully there are white lines or white striations. So that white lines or white striations on the lateral border of the tongue is nothing but oral hairy leukoplakia. Again, it is caused by EBV. But remember, this is characteristically seen in HIV patients. You don't see in any of the other cases. Oral hairy leukoplakia is characteristically seen in HIV positive patients. So all these points are important. The image itself is very important. If you see white striations on the lateral border of the tongue, immediately what should come to your mind is oral hairy leukoplakia. Oral hairy leukoplakia. Okay, so all these are the viral infections that I just wanted to cover here. That is the mainly the herpes. So these images are very important. I'll just revise in a flash that this is the herpetic gingivostomatitis. This is herpes simplex secondary, that is which affects the lips. This is the herpetic whitlow. This is the herpes zoster of the palate. Herpes zoster of the palate. You should note that unilateral vesicles will be there, mainly in the herpes zoster. Hand, foot and mouth disease. Remember, the ulcer never affects the gingiva and lips. Gingiva and lips. Herpangina typically affects the posterior part of the oral cavity, never affects the anterior part. Typically, it affects the palate, soft palate, fascial pillars and all those things. Infectious mononucleosis. You have to identify these as pinpoint hemorrhagic dots on the palate, that is palatal petechium. Then Koplik spots are very characteristic, bluish white spots. We can easily identify those bluish white spots on the buccal mucosa. On the buccal mucosa. Okay, the last one here is the oral hairy leukoplakia. So this oral hairy leukoplakia is characteristically or always, mostly or not mostly, always seen in HIV positive patients. It is caused by Epstein-Barr virus and it has got white vertical striations on the lateral border of the tongue. Okay, so that's about the viral infections. Let us move on to the bacterial infections. The most important bacterial infection we are going to start with here is the scarlet fever. All of you can see here carefully. This is the tongue which is called as strawberry tongue. You have to identify this image, strawberry tongue. So strawberry tongue is seen typically in scarlet fever, and this scarlet fever is caused by Streptococcus pyogenes. Streptococcus pyogenes. So it is a streptococcal infection. It is mainly a streptococcal infection. Second one is about the oral TB, tuberculous ulcers. So TB, all of us know, the ulcer that occurs in the TB patient is a characteristic location is tongue. Please remember, the most, if you can see that image, typically the ulcer is seen on the tongue and it is very large ulcer. Look at the diagram. Look at the ulcer there. It is very large ulcer. It is so large ulcer that it looks like a malignant ulcer. Usually they get confused that it is a carcinoma tongue. It will be so large. Okay. And these ulcers are very painful ulcers. They are very painful and they have got undermined edges. Okay, they have got undermined edges. So typically we should know about the edges. Okay, so ulcer that is seen on the tongue and it is painful ulcer, which is a large ulcer resembling the malignant ulcers, and they have got usually undermined edges. Undermined edges. This is nothing but the multiple cervical lymph nodes, TB lymph nodes. This is known as scrofula. This is known as scrofula. Yes, this scrofula is nothing but the tuberculosis of the lymph nodes. Yeah. This is a typical image of the leprosy patients. We know that leprosy is of basically two types: tuberculoid leprosy and lepromatous leprosy. So characteristically, you will see the mucosal lesions on the palate. You should remember this. Where do you see most common site for oral lesions in leprosy is palate. So on the palate, you are going to see these mucosal lesions, that is lepromatous leprosy patients. So in lepromatous leprosy patients, characteristically you will see the mucosal lesions. So usually single liner MCQ comes, most common site for oral lesions in leprosy is, answer is palate. Answer is palate. Okay, this is a chancre. All of us know chancre typically occurs in the syphilis patients, primary syphilis, and look at that, it's a single lesion. It is a single lesion. It is solitary. It will not be multiple. It's a solitary lesion that usually occurs on the lips, and they are painless. They are painless. Please remember, they are never painful. Syphilitic ulcers are painless. Painless. Okay. Now, secondary syphilis. If you see secondary syphilis, primary syphilis is chancre. We have seen that chancre that it typically occurs on the lips. Usually they are solitary. Remember that. But secondary syphilis will have mucus patches. You can see on the lips there are 3 patches there. They are called as mucus patches. So mucus patch is a characteristic lesion of secondary syphilis. Now these patches, if we try to remove, scrub, so that patch will get removed and you will get an ulcer called as a snail track ulcer. So snail track ulcer, where do you see secondary syphilis? Okay, so these mucus patches, if they are rubbed off, you will see snail track ulcers. Now this is another image to show the skin rash that is seen in secondary syphilis. That's not characteristic. They won't ask it. This is condyloma lata that is seen in secondary syphilis. This is very important. You can see here carefully at the angle of the mouth, you will see one papular lesion. That is called as condyloma lata. So what is condyloma lata? Is a papular lesion seen at the angle of the mouth. Now this is interstitial glossitis. What do you mean by interstitial glossitis? It is nothing but the other term for the tongue enlargement that is seen in tertiary syphilis. So in tertiary syphilis, what happens is the tongue will get enlarged. Why the tongue will get enlarged? Because in tertiary syphilis you will see gumma, and that because of that gumma on the tongue will get enlarged. That is called as interstitial glossitis or syphilitic glossitis. Syphilitic glossitis. Okay. Now moving on to this next image. Yes, this is a Hutchinson's teeth. All of us know this is a Hutchinson incisor. Characteristically, I'll show you one more tooth, one more image of Hutchinson incisor. This is a Hutchinson incisor where you can see a notch on the incisal edge. Where you can see a notch on the incisal edge. This is a mulberry molar, which is again a characteristic Hutchinson's tooth appearance. Hutchinson's tooth appearance. Now this is an image of a dark ground microscopy. So these are spirochetes. You can see carefully here the spirochetes. This is a very characteristic image of dark ground microscopy. Now this is an image of actinomycosis. You can see here carefully. In this image of actinomycosis, typically which is caused by Actinomyces israeli, these patients will have multiple draining sinuses on the neck. That is a characteristic clinical identification point. They will have multiple draining sinuses on the neck, and those sinuses will produce pus, and those pus will contain sulfur granules. So sulfur granules which are seen are nothing but your colonies of these bacteria. So this is a very characteristic image I'll show you now. This is a sulfur granule, characteristically a sulfur granule. Okay, that one big thing is your sulfur granule. We have one more small sulfur granule. That all those are nothing but your colonies of this bacteria. Okay, colonies of this bacteria. So very commonly or very famously you call this as a ray fungus. Ray fungus. Okay, because of the characteristic appearance, radiating nature, we call this particular bacterial infection as a ray fungus, which is a misnomer actually. It should not be used because this is a bacterial infection. This is not any fungal infection. Okay, this is not important. Yeah. This is an image of ANAG. ANAG is acute necrotizing ulcerative gingivitis. Typically, what are we supposed to remember in this image is the punched out crater like lesions. On the gingiva, you will not see the smooth lesions, rather you will see punched out crater, that is deep ulcers. Deep ulcers. That's about the bacterial infections. So we have completed the viral infections, we have completed the bacterial infections. So characteristic images are whatever I have shown you, and these are the characteristic image based questions which are very frequently asked in INICT paper or your NEET paper. Okay, now you have to identify these whatever images I have shown you till now are characteristic. That means they're specific for that only. Like for example, interstitial glossitis is typical for tertiary syphilis. The Hutchinson's teeth is a specific for the particularly the congenital syphilis. Okay, you should be able to identify the lesion. Now, pseudomembranous candidiasis. Now, this pseudomembranous candidiasis is basically a classic curdled milk appearance. That is a cottage cheese appearance. You can see that white patch that can be easily scraped off. Now, this is an image of the denture stomatitis. Denture stomatitis. Okay. Denture stomatitis is also known as chronic atrophic candidiasis. Basically, chronic atrophic candidiasis. There is a very common single liner MCQ also. That is a person called as a Newton has classified this. Denture stomatitis. Okay. So we are supposed to remember this chronic atrophic candidiasis, also known as a denture stomatitis. Now this is a candidal hyphae. If I stain with a PAS stain, per iodic acid Schiff stain, I will be able to see such pink colored rods. They are nothing but your candidal hyphae. Now this is angular cheilitis, again which is also known as Perlichet. Very frequently we call it as Perlichet. Remember why I am covering this in fungal infections is because it is caused by Candida. It is also caused by Staphylococcus. Remember that. So there are two organisms. One is Candida, one is Staphylococcus. Both of these can cause this angular cheilitis. Okay, now this diagram is very important. This is of a mucormycosis. Typically, we can see here the mucormycosis is a fungal infection which affects the rhino region, that is the nose region. Okay, so basically what happens is you will see necrosis. That black color what are you seeing is necrosis. Now how to identify? Even aspergillosis also looks like this only. Same like mucormycosis, aspergillosis also looks like this only. Then how do I identify? How do I prove that this is mucormycosis? By seeing the hyphae. If the hyphae are branching at right angles, you can see here there are two hyphae here, and those two hyphae both are branching at the right angles. This is one hyphae and this is one more hyphae. And look at this angle. If I draw a diagram here, if I carefully draw this angle is 90 degrees. This angle is 90 degrees. So typically the hyphae branch at right angles. So that, and remember, the hyphae are non-septated. Non-septated, that means they don't have any septa here basically. How to differentiate between that and aspergillosis? Aspergillosis also clinically looks the same like mucormycosis. But the difference here is the hyphae that you see here are septated hyphae. Whereas in mucormycosis it will be non-septated, here it will be septated hyphae. Septated hyphae. Okay, so that septated hyphae results that will be able to, and even the look at the size also. If you carefully see here, look at the size. What is the size of the hyphae here? They are very large, ribbon like. Whereas if you see the hyphae here in aspergillosis, they are very small hyphae. So two differences we should be able to identify in the image. One is look at the size, one more whether it is septated or non-septated, one more is branching. Branching at right angles you see in case of the right angles, or obtuse angles you see in case of mucormycosis, whereas aspergillosis they usually won't branch, and if they branch also that is at an acute angle. Okay, branching is not that characteristic here. Hyphae are septated in case of aspergillosis. Okay, so this is a session for today about the discuss part 1 image based discussion for the subject of oral pathology. So I have tried to cover the most of the images which you can expect in the exam about the viral infections, bacterial infections, and the fungal infections. So in the next part, we will be covering with the next topics, that is the tumors, mainly benign and malignant tumors, salivary gland tumors, cysts, odontogenic tumors, then you have bone. Okay, we'll in subsequent sessions we'll be trying to cover that. Okay, I hope this session would have been helpful for you, and we will have such sessions more. And any doubts you can put it in the comment box. I'll just go through your doubts and will be definitely happy to solve your doubts. Okay, thank you so much. Thank you.